All right, the recording has started. Welcome. This is the April 2022 P&T committee meeting. We have had 7 of the committee members join, so we have a quorum so that we can conduct business. I see the staff is in attendance also in the participant panel. So it's 5 minutes after, and I propose we get started. We're going to start off with roll call and introductions. We have listed on the page the P&T committee members with their title and position that they hold on the committee and their expiration date. We'll start from top to bottom. If you can unmute yourself and introduce yourself. We'll start with you, Pat.
Sorry, guys. Technical issues. I'm unmuted. Pat Martino.
No worries.
I'm a pediatrician at OHSU in the Division of Hematology Oncology.
Great. Welcome. Kat, are you able to unmute?
Hi, this is Kat Livingston. I'm the medical director of healthcare. I'm also a practicing family physician.
Welcome. Stacy isn't able to join us today, so actually Bill Orger, the co-chair, will be stepping in, helping orchestrate the meeting today. But we'll turn it over to you, Tim.
Yeah, I'm Tim Langford. I'm the pharmacy director with the Klamath Tribes in Chiloquin, Oregon, rural health care clinic.
Welcome. Karen Michelson also was not able to join us today for this meeting. So Robin, to you, please.
I'm Robin Moody. I'm a public member of the committee and I'm executive director of General 3.
Welcome. Bill?
Bill Orger, family physician. I'm on the faculty of the family medicine residency program at Samaritan Corvallis.
Welcome, Bill. Mark Helm also isn't able to join us. I do have assurances that he'll rejoin the fray in June. So looking forward to that. Russ, over to you.
Hey, can you still hear me okay?
Loud and clear, Russ.
Excellent. Okay. Russ Huffman, psychiatric nurse practitioner at Salem Health.
Welcome, Russ. Another public committee member. And Eddie?
Good afternoon. I'm Eddie Saito, associate professor at the School of Pharmacy at Pacific University and clinical pharmacist with Virginia Garcia.
Welcome. Thank you, Eddie. We'll also do introductions for staff. This is a sound check for us, be able to make sure that you're able to unmute yourself. Jennifer, I think I saw you, so we'll start off with you. You might have snuck away, so I will step up. Roger Citron, Director of the Drug Use Research and Management Program. We provide clinical support to the OHA to help with the pharmacy program and run these P&T committee meetings. Trevor, I know he's joining us, but he's triple or quadruple booked today. Let's go over to you, Dave.
Hi, I'm Dave Ingen, OSU clinical pharmacist with the Derm team.
Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators for the Derm team.
Andrew Gibler. I am a clinical pharmacy manager at OHA.
I'm Kyle Hamilton. I'm the pharmacy drug coordinator here at OHA.
I don't think Megan has joined us yet. Again, another person that wears many hats. I believe she'll be joining us later in the meeting if we need some clinical support. So we'll turn it over to you, Deanna.
Hi, I'm Deanna Moretz. I work with the Derm team as a clinical pharmacist.
I also haven't seen Amanda join us. Kathy Centena, we'll turn it to you.
All right. Thanks, Roger. I'm Kathy Centena, and I'm a clinical pharmacist with the OSU Derm team as well.
And hi, my name is Sarah Servid. I am P&T clinical co-coordinator with Sarah Fletcher in that job and with the OSU Derm group.
Hi, I'm Lance Starkweather. I'm the pharmacy manager for Gainwell Technologies.
I'm Deborah D. Weston. I'm the pharmacy program policy advisor with the state, focusing mainly on Medicaid.
Hello, I'm Brandon Wells. I'm the pharmacy program analyst for OHA. I cover the fee-for-service program.
And Megan, I saw you join as we just passed your name. Brief introduction.
Yes, hello, I'm Megan Herring. I'm a clinical pharmacist with Derm and the College of Pharmacy.
And Trevor, we had also run over past your name. I know you were triple, quadruple booked, but if you want an opportunity to introduce yourself. Does help if I make you a co-host so that you can unmute yourself, Trevor.
There you go. Trevor Douglas, OHA Pharmacy Director. Thank you very much.
Welcome. All right, moving on, we have the approval of the agenda and conflict of interest declaration. We have no changes proposed to the agenda we've put forth for the meeting today. Conflict of interest declaration. Conflict of interest is vitally important to the OHA. All staff and P&T committee members are required to have an up-to-date, accurate conflict of interest declaration on file with the OHA. Additionally, anybody that provides written public comment or wishes to provide up to 3 minutes of public comment during the meeting today has been asked to submit their conflict of interest declaration. We do, however, provide an opportunity at this point to see if any committee members have a new conflict that they need to disclose or any items on the agenda today that they'll need to recuse themselves. Hearing none. We'll move on for the approval of the minutes. The minutes have been sent out to the committee in advance. They had a chance to review from the previous P&T meeting held in February. So we'll see if the committee has any edits they need to propose. And if not, we'll need a action motion to approve these minutes.
So moved.
Second.
Thanks, Robin.
Second.
Thanks, Bill and Pat. All in favor?
Aye.
Aye.
Any opposed? Abstain? Great. Thank you for the approval. With that, we'll turn it over to Andrew Gibbler for the department update.
Hello, this is Andrew Gibbler. We don't have any specific updates this month, so I just want to take the opportunity to thank each of the public members of the committee for their service and for the Durham team for all the wonderful work that you do running this program. I don't have anything else.
Well, we'll take that. Thank you, Andrew. Appreciate you in the fray with us. So we'll have the legislative update. We had the short session conclude. Dee, we'll turn it over to you.
I'm sorry, I missed that. I don't know that I have any new legislative updates. I think the last meeting that we had was at the end of session and nothing has changed since then.
That's always good that nothing's percolated up.
Was there something that I was meant to speak to? I apologize.
There was nothing specific other than sometimes we have different pieces of legislation or some carryover once things start to get traction that is important to the committee. And I don't know if the committee had any specific questions for the OHA in regards to the short session. Great. Hearing none, we'll move on to the consent agenda. We always have a standing placeholder for our oncology and orphan drug policies to add new agents. So I just wanted to let the committee know that we did have a representative from Sanofi, Brandon Yip, that signed up to provide public comment for the new orphan drug that is being added to the policy. But he did acknowledge that he would give the time back to the committee and wouldn't provide any public comment if there were no questions and if you didn't wish to take that off the consent agenda. So we either need to see if the committee wishes to take anything off the consent agenda to discuss, or a motion to approve the recommendations in the oncology policy. And again, the oncology and orphan drug recommendations are to add the new FDA-approved antineoplastic agent to Table 1 for oncology and update Table 1 in the orphan drug policy to reflect the recently approved agent.
Motion to approve the consent agenda as written and move on.
Thank you, Robin. Great. Thanks, Russ. All those in favor?
Aye.
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 Any opposed? Any abstention? Great. Those will be added. Thank you. The next topic we have on the agenda, and again, for the audience, we have posted all of our materials to our website. The full packet of materials is out there. If you're following along on the posted packet, we'll be moving to page 25. We're going to turn it over to Sarah Servid and the Citizen Waived Medical Coverage Update.
Thank you. Yeah, and today I'm going to be presenting a coverage policy for the Citizenship Waived Medical Benefit. And this benefit is available to non-citizens who also meet standard definitions for Medicaid eligibility. They're eligible for emergency treatment coverage and can be covered under this benefit. Coverage for this benefit is limited to emergency treatment, which is state defined. And this definition can include drugs or conditions which wouldn't necessarily only be treated or administered in an emergency department. So Oregon has defined emergency coverage as diagnoses for which the absence of treatment could result in serious jeopardy to the health of the patient or an unborn child, serious impairment to bodily functions, or serious dysfunction to any bodily organ or part. And currently there are about 40,000 patients in Oregon who are enrolled under this benefit plan. And because funding is limited, Oregon is taking a stepwise approach to expanding coverage for this population. So coverage of conditions that are currently covered include cancer, dialysis for end-stage renal disease, and immunosuppressants for kidney transplant. And as we secure funding, the plan is to expand this coverage to other conditions as funding allows. And so the purpose of this PA criteria policy is essentially to evaluate whether prescribed drugs meet this emergency definition for these patients. So with that, I'll go into some of the specifics of the PA policy. The policy essentially asks whether treatment is related to any of the diagnoses that the state has decided meet this definition for emergency treatment. And we do have a table of conditions for diagnoses that are currently covered. The second question in this criteria asks if treatment is for preventative therapy, because kind of by definition, preventative therapy isn't an emergency. And then the state is also electing to cover any ancillary diagnoses which are related to that covered condition. So for example, we will be covering cancer treatment, and we'll also be covering nausea and vomiting that's associated with that cancer treatment if it's a highly metagenic cancer regimen. And the final question in this criteria is kind of a catch-all question because it's not really possible to imagine all of the potential covered ancillary diagnoses. We want to provide the provider an opportunity to send in any information on related covered conditions that are pertinent to one of the covered emergency conditions for this population, and the supply chart notes and whatnot for coverage consideration. There are a few recommended updates to this policy which aren't in the packet, and these are outlined in red here on the screen. And it's mostly clarifying duration of coverage. So allowing coverage for the length of the prescription or requested duration, whichever is less for covered conditions. And then providing a maximum allowed duration for each of the different diagnoses. And this is mostly to address behavioral health conditions associated with behavioral health crisis. The state is, that's one of the conditions that the state is electing to cover in addition to these other ones, and is expanding coverage for this population. And so we would be covering that for up to 3 months, or for the length of the prescription, whichever is less. And so in summary, the recommendations for this policy would be to implement this prior authorization criteria for the CWM benefit, and then as the state expands the benefit in this population, to add new conditions to these tables in this criteria to allow coverage for expanded conditions in future. And I'd be happy to take questions if people have them.
Sarah, this bill already all start out with figuring out how to interpret this. When you look at something like cancer treatment, that covers a huge area. It would cover things such as early treatment of carcinoma in situ of cervix, breast, prostate, where there really isn't any malfunction, but you want to get it early. Does this cover any and all standard cancer treatments? You know, for example, what about kind of a last, at the other end of the spectrum, a last ditch palliative effort in someone with a limited lifespan in whom this might buy time or reduce symptoms but not change prognosis? Are all of those covered, or how do we administer this?
Yeah, that's a good question. They are all currently covered with this proposal. And so the intent is if the patient has cancer, you know, has that diagnosis, that treatment for it would be covered so long as they currently have that disease and aren't in remission.
Okay, well, that helps. And with that in mind, then our job is simply approving the standard drugs used to treat all these things, and we should be able to do that.
I would say, is the 12-month maximum allowed duration like obligatory, or could we adjust that? Because you think of things like, if you have like CML, you're going to need a lot more than 12 months of drug, or for lots of cancers, really.
Yeah, that should probably be clarified. So the intent is it can be approved for a duration of 12 months. After that 12 months, they can send in another request and it can be approved for another 12 months. So it's kind of a standard PA process in that we typically approve it for a year, and if they need additional therapy, they can request it. So yeah, we can change this language here so that it doesn't sound like it's 12 months total.
Along that line, this is like emergency medicine. And so I just want to confirm that normally when I think of emergency, I think of shorter durations of therapy. So is that in line with what the legislation was seeking or the intent of this?
Yeah, because the state can define emergency, you know, can create their own definition of emergency within certain parameters. Because they're defining it as the, you know, the absence of treatment could result in serious jeopardy, impairment, dysfunction. The assessment has been that these, you know, cancer does meet that definition, even though it's a longer term treatment in some cases.
I guess I'll just make like an obligatory comment and then maybe a motion to approve, but like, I think it probably all just feels weird because like there's lots of stuff that's as bad or if not worse than lots of cancers acutely. But I think as written, the PA criteria look okay to me, and I guess I'll make a motion to approve.
Is there a second?
Second.
All those in favor?
Aye.
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 Okay, anyone opposed? Or abstain?
I'll abstain.
One abstention? Okay. But no opposition. Is that correct? All right.
Was that Cat abstaining?
Yeah, no opposition. I just, there are a lot of really important things to cover.
So noted. Thank you.
Great.
Okay, onward.
The motion passes then. Anything else on this topic, Sarah? Great. I think you're on mute. We'll move on. The next topic is prior authorization updates. We'll still leave it with Sarah. Direct your attention to page 28 in the packet posted online.
Yeah, so these next few updates should be relatively straightforward. We're just hoping to provide a little bit more clarity in the PA criteria because of questions that have come up during the PA process. So the first PA criteria that we're looking at is botulinum toxins, and we're clarifying the language for overactive bladder disease in this criteria, and then providing some slight updates to the language regarding step therapy for migraine drugs. So that you can see the changes outlined in the packet here. Most of the changes are regarding question 6, and this is where we talk about step therapy for preventative migraine treatment. And we're just clarifying this question to list specific drugs rather than classes of drugs, because there are some specific drugs that have been studied for prevention of migraine, and so listing the specific agents in the criteria here rather than the classes. And then the other questions regard detrusor muscle overactivity or overactive bladder. There are providers that send in a whole host of ICD-10 codes for this, and they probably meet the definition of overactive bladder disease even if they don't send in that specific ICD-10 code. So we're recommending removing the reference to the ICD-10 code and just listing overactive bladder in here. And then also clarifying in question number 9, step therapy for our preferred products, and then listing some of our non-preferred products here, and still requesting that they try 2 of those oral products before they move on to a botulinum toxin. And then other edits are mostly clerical, just cleaning up language. And I believe that is it. Any questions on this criteria before we move on?
And otherwise, we can take each criteria individually, or our intent was to propose these as a group and then take action in one fell swoop.
I think that'll work.
Are there
We've got
any questions or concerns about these or public comment? Hearing none, I need a motion.
So moved.
And a second?
Second.
All right. All those in favor of the package as presented?
Aye.
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 Anyone abstaining? Anyone opposed? Motion passes.
And again, I kind of confused things there, Bill. That was the first of 3, but I think it's probably wise to take them in order. So we'll take the first one, the botulinum toxin PA changes as approved.
Great.
And then these next 2 criteria pertain to the same topic. And so HERC has updated, the Oregon Health Authority has updated Statement of Intent 4, which addresses role of the prioritized list for conditions in patients under 12 years of age if treatment is expected to improve the patient's ability to grow, develop, or participate in school. And so the intent with this Statement of Intent number 4 is that a child's ability to grow, develop, or participate in school should be considered when you're considering treatment for an unfunded condition. And so in alignment with that, statement, we're recommending updating our prior authorization criteria for non-preferred products. So this criteria applies to non-preferred products where we don't have specific clinical PA criteria, and then also the specific PA criteria that we have for drugs for non-funded conditions. And the changes are to essentially add language regarding patients that are 21 years of age or under, and consider whether treatment of an unfunded condition would affect their ability to grow, develop, or participate in school. And so this is the language that has been added to the non-preferred drug criteria, and then also similar language to, for the drugs for non-funded conditions. Any questions on that?
Do we need to vote on this, or is there more?
This is it, and we do need a vote.
Okay. Motion, please.
Move to approve.
Second.
All those in favor?
Aye.
Aye.
Anyone abstaining? Anyone opposed? Passes.
All right, great. Thank you, Sarah. All right, continuing on. The topic du jour. I'm busy in the background, so I apologize for my delayed getting off mute. I've had about 4 more people wish to provide public comment on this topic. So we're going to be talking about the hepatitis C direct-acting antivirals policy discussion. This is something that's been ongoing. Well, Hep C coverage and DAA has been going on for years and years, and this policy discussion has been brought to the committee on a couple occasions. But I'm going to turn it over to Andrew Gibler to kind of set the stage and direct your attention to page 39 in the packet if you're following online.
Thank you, Roger. This is Andrew Gibler, and I would like to present the current policy recommendation to remove prior authorization for treatment-naive individuals seeking direct-acting antivirals for hepatitis C that are identified on Oregon's fee-for-service PDL. And this recommendation comes from the Oregon Health Authority fee-for-service Medicaid program. The OHA appreciates the consideration the P&T committee has made to prioritize treatment when these agents were first approved, and we had limited real-world experience using these antivirals and limited data on the real-world safety and effectiveness. But as real-world experience increased, the community standard has evolved. For many OHP patients, their first visit with a provider about their hepatitis offers a critical opportunity to help them begin to achieve positive health outcomes. However, the prior authorization requirement itself can cause delay in therapy, which increases the risk of ongoing transmission in the community of our most vulnerable citizens battling addiction. Today, we have seen multiple prescribers across the state successfully treat thousands of OHP patients. These providers are now familiar with the implications of these treatments and how to care for their patients to ensure successful follow-up. At least 11 states have removed prior authorization criteria for preferred direct-acting antivirals for hepatitis C in treatment-naive patients. And these states have not seen evidence of inappropriate prescribing, lack of care coordination, or significant increases in drug costs and retreatments. As OHA works to eliminate health inequities in Oregon, by 2030, we encourage the P&T committee to weigh the clinical data of these agents and the public health implications of this curative treatment, and hope that you can support the recommendation to remove clinical prior authorization for preferred agents on the fee-for-service PDL. We also want to thank you for your public service and continued support of Oregonians on the Oregon Health Plan. So with that, Dee, Weston, if I missed anything else you would like to share, I'll pass it on to you. If not, we'll pass it on to Megan to present the prior authorization criteria.
I don't have anything significant to add, and I suspect this will come up later, but I just want to note that this is the kind of the first stage in the consideration Questions about risk corridor, contract operations, and things like that are also important, but will be considered after we know what direction the agency will go based on P&T recommendations. Thank you.
Thank you, Dee and Andrew. So before I go into the PA criteria, I just want to highlight the second recommendation that we have listed here. As a reminder, we brought back an evidence review in the last 6 months. So we are not bringing any new evidence to the P&T committee today. But we are recommending, as Andrew mentioned, to remove PA criteria and required case management for preferred DAA regimens for treatment-naive patients. And the second recommendation is to make sofosbuvir, velpatasvir, voxilatravir, or Wasevi non-preferred and continue to reserve it for treatment-experienced individuals. Now, if you want to scroll down to the PA criteria. So this is the updated PA criteria that we are proposing that can be found on page 41 in your packet. And so again, this PA criteria is for any prescribed non-preferred DAAs, as well as for any direct acting antiviral for a patient who is treatment experienced with the DAA. So scroll down, we are just asking what the diagnosis is, and that it's a request for treatment of hepatitis C infection. Number 3, we are asking for pre-treatment testing for those in which it's applicable. So genotype testing is required if the patient has decompensated cirrhosis or has prior treatment experience with a DAA regimen, or if they are being prescribed a non-preferred regimen that is not pangenotypic. And then if they are treatment experienced, to get more history about their previous treatment and the outcome from that treatment. And then 4 and 5 are just asking if they have been treated with a DAA before. And then 6 and 7 is really getting at is if it is a treatment failure or if it is reinfection. And so asking if there was a SVR after completion of their last DAA regimen. And if so, getting more information if it is likely a reinfection, if not, treating as the guideline recommended regimens for treatment experienced individuals. And then number 8 has been in our PA criteria, just asking for the recommended baseline resistance testing for those regimens where it's recommended. And then lastly, number 10, just making sure it's for a recommended regimen and appropriate duration according to the treatment guidelines. And that is it.
Thank you, Megan. Any questions from the committee for Megan on the proposed changes?
Yeah, Megan, this is Tim. Just a quick logistics question. It sounds like we'll have 3 preferred options for Hep C treatment that will not require a PA unless there's prior experience with DAA. Logistically, how will OHP be checking that, knowing that patients go on and off of OHP all the time and we may not have drug history through the OHP system?
That's a good
Great question. First, I'll step in just to say that we're talking about 2 preferred agents. So it would be, yeah. Sorry,
Yeah.
Go ahead, Megan.
No, yeah, the 2 preferred are Mavyret or Epclusa, generic Epclusa. But yeah, that's a good question. And I know there's been conversations, and Roger, you can probably answer that better than I can in terms of how to identify the treatment experienced individuals.
This is Robin. Oh, go ahead.
I was going to say it is definitely a gap in our system. One thing is that patients do move on and off Medicaid, and so if we do have that history, we can do a long look back if we want to capture that. But it is definitely a gap in our system.
This is Robin. I just wonder kind of what has changed in that this recommendation is coming forth. I believe, perhaps prior fears about cost or just therapeutic integrity maybe held you back, or what, I guess why is the committee feeling that this is the right time and place to bring this forward to end prior authorization?
This bill, I think maybe I can comment on this. I've been involved in this whole fray, and unfortunately similar frays over a lot of years. As this has been pretty well explained, this is now a mature therapy. When we began, it was a cutting edge therapy that was very expensive, and there was very, very limited research. And all we knew at first was that it seemed to cut down the viral load for a short period of time, and that's all we knew. And in the meantime, the treatment has matured, competition has lowered the prices. We found that the toxicity is almost none and a huge improvement over prior. And
excellent. That really helps.
So
therapeutic advancements, you would say, as well as cost reduction.
Yeah, it's the whole maturity of the process. And, I was one of the ones that was waving the stop flags, but I support this. I think it's just a logical clinical evolution of a treatment that's gone from experimental to standard.
And we've kind of been slow walking toward this anyway. I mean, expanding coverage and access, and so it's just kind of the next step in a progression that we've made over the last several years.
This is
Appreciate
Eddie.
that context very much. Yeah, I think that covers it for me.
This is Eddie. I have just a clarification question. So would this then allow for those two preferred treatments in treatment naive patients, regardless of status of cirrhosis, presence of cirrhosis or status cirrhosis? Is that right?
Yes, that's correct.
Thanks. I also, just for the record, I also think this is a great idea. I think from our perspective in primary care, it will definitely reduce time to treatment and offload a lot of the burden from our providers who are eager, and our screening patients and eager to treat those that they can, and just get that going faster. So I think it's going to be a great thing.
Are there committee members who have reservations about this? We've had several statements of support. Are there still reservations?
Or additional questions for either the policy, for Andrew, Dee, or clinically for Megan? We will have. We at this point have. I have 9 people that are wishing to provide public comment. It's growing by the second. I keep checking my inbox. So, Bill, maybe those questions for the reservations might be addressed by the pros and cons that we're about to hear. In addition, we've received written public comment, 5 of which I sent to the committee in advance, brought your attention to review. I did just receive one moments ago from Representative Lisa Reynolds in support of removing the criteria. So just wanted to vocalize just the brief that it was in support of removing this. But questions specifically on what's been said by Andrew D. or Megan?
Kat, you have a question?
So I think, this issue of you kind of need the PA in order to figure out whether or not they're treatment naive or experienced. That seems challenging to figure out if you don't have the PA to know whether or not that's true. So that does seem like an operational thing that needs to be figured out. I think the other thing that's really come up in conversations about this is essentially eliminating the case management piece. So fundamentally, if getting access to the medication, 24 to 72 hours earlier is worth so much that the case management essentially is no longer available. So, from a CCO perspective, if you have the PA, that's what triggers the case management to happen. And some clinics are doing amazing case management and they aren't using the CCO at all. And all of that support is fully built in the primary care side. But in some cases, it's really, the CCO is doing a lot of that case management, and that's really important. And so just trying to figure out, so first of all, if the PA goes away, the ability to case manage from the CCO perspective goes away totally. And so I'm just worried, what is that loss? How much will that affect treatment adherence and, not have gaps and things like that? And then I do have questions about what this means for the risk corridor and then what CCOs will be expected. There are deliverables about case management, but those wouldn't be able to be delivered upon anymore.
Answering your second question first, that's really going to be operationalized by the OHA, depending upon the recommendations that come out of this committee and get to the OHA, Director Allen, for consideration. Going to your first questions, those are exactly what we'd like to hear right now. With the number of people that we have signed up to provide public comment, I think you've teed up some questions that can really maybe hone their comments so they can address those concerns. So I think you did a great job, Kat, teeing up what are the concerns with the loss of case management for the treatment naive for preferred agents. Any other comments or questions from the committee that you'd like to put on the table so that the people that are providing public comment have something to focus on that provides value?
Could simply the request for, or the filling of a prescription trigger case management?
Kind of chasing your tail. It depends on how quickly you'll see those claims. And, some of the case management, I think, as you'll hear from some of the people that will provide public comment, is on that front end to their processes that actually facilitate the filling and access of those medications. So it depends, Bill. Yeah. But I don't want to take the wind out of the sails of people that are going to provide comments. So any other questions from the committee that you want to make sure that are addressed by the commenters? Okay, I am going to aggressively share my 3-minute timer. We have, again, a lot of people. We're going to start out with Charlie Levan with ABV. Signed a public comment or disclosure of conflicts, works for AbbVie, manufacturer of Mavyret. So Charlie, are you able to unmute yourself?
I have, yes. Hi, good afternoon.
All right.
The
floor is yours.
Good afternoon. My name is Charlie Levin with AbbVie Medical Affairs. Thanks for the chance to speak today. I appreciate the board's continued efforts to address patient access and curative treatments for chronic hepatitis C by reviewing and revising these PA criteria. As a brief reminder, Mavyret is an oral, once daily fixed dose combination of two pan-genotypic agents, glucoprevir and preventosvir. And it's approved for the use of all HCV genotypes, including patients with chronic kidney disease, stages 4 and 5. Among patients eligible for Mavyret, it's estimated that 98% of treatment-naive patients are eligible for 8-week treatment. So I'll keep my further comments brief, as I believe the committee is aware of the clinical details of Mavyret. The committee has been successful in driving healthy and positive outcomes for HCV patients by expanding access to treatment in a multitude of ways. In that vein, AbbVie agrees with the proposed recommendation and respectfully asks that the committee continues on that path by removing the PA criteria for preferred direct-acting antiviral agents for the treatment-naive patients with HCV. This action would align with the U.S. Department of Health and Human Services recommendations for removal of PA criteria and the effort to eliminate HCV. In addition, this would make Oregon the 13th state to take such steps, including Washington, Alaska, and California. And lastly, in regards to potential utilization impacts, an internal AbbVie analysis of 2 states that lifted PA restrictions in 2020 showed no permanent increases in new patient starts, but rather a return to the mean after about 6 months. Thank you again for the opportunity to speak today. I'm happy to field any questions regarding Mavyret at this time. Thanks.
Thank you, Charlie. Any questions for Charlie? All right. Stuart OBrien. You're a known entity. Great. There you go. We get to see
Good
the.
to see you again. So I don't know if you can see this,
You bet.
Roger, but it's one of my newer
Go, Jerry.
yeah, Jerry ties. So anyway, wish we could be in person to see everyone, but I'll make my comments brief as well. And I want to commend the committee and the OHA for considering this recommendation to fully open access to the patients of Oregon continuing to suffer from chronic hepatitis C. And I also want to commend the committee and Bill for recognizing being responsible with this therapeutic area, but now recognizing the breadth of data that is out there to support removal of this PA criteria. I'd like to just highlight a new piece of real world evidence that really just supports where you're going with this. Last week at AMCP, the National Managed Care Pharmacy conference, Kaiser presented a study of almost 8,000 patients where they did a real world analysis of both the health and economic benefits, which have both been highlighted already for the treatment of hepatitis C with DAAs. And they brought up that that is cost effective. It is, the authors indicate that this finite therapy has been a good investment in healthcare resources, even though there's a significant upfront cost. They studied it from the period of 2010 to 2019. So that, as already brought up, has reduced. I'll just highlight what they came out with, the conclusions of the model briefly. With that 7,000 plus patients, almost 8,000, they reduced the number, they estimated that they would reduce the number of compensated cirrhosis cases by over 3,000, the decompensated cases by about the same amount, and actual end liver related mortality by about 3,000 in the scenario that they did. They happen to have used soft-based regimens, but either regimen is currently on your available list, are very effective at doing this. And they found that it led to a cost savings after only 3 years. And they use WAC pricing, which we know in the Medicaid space, WAC is not your reference price. So at least 3 years, but I would argue less in Medicaid as you open this up. So the benefits of health and cost are definitely have been demonstrated, in this study just supports that. So I thank you for your consideration. Thank you for your time today. And I appreciate what you're doing for the patients of Oregon in this disease state and the many others that you have to contend with. So thank you very much.
Great. Any questions for Stuart? You're breaking up, Stuart, so I think that means we're at 3 minutes. So any questions for Stuart?
I didn't go over this time, Roger.
All right. You know me, I'm a stickler. Next, we'll turn it to Amy Burns, the Director of Pharmacy for All Care. Amy, are you able to unmute yourself?
Yes, can you hear me, Roger?
You bet. We hear you loud and clear. The floor is yours.
Thank you. Good afternoon. My name is Dr. Amy Burns and I work for All Care CCO. My CCO generally does not provide testimony for the fee-for-service P&T committee because CCOs have our own PDLs and P&T committees. And while the decisions that the committee makes are definitely of interest to us, they usually don't affect us. But the medication class for DAAs is different. CCOs are required by current contract to follow the fee-for-service criteria for this class. There is a risk corridor in place for contract year 2022. And part of the risk corridor is to ensure that case management occurs. We're required to provide this. The proposed PA criteria directly contradicts our current contract requirement. And we believe that this should be tabled for CCO input and to allow for operational changes for an implementation at the start of a new contract year. Although the review mentions 10 other states have removed PA requirement, it did not provide any evidence that removing the PA requirement will increase access to treatment. The idea appears to allow for immediate dispensing of medication, but in our experience, in the 3 mostly rural counties that we serve, most prescribers do not have a pharmacy on site. The medications are usually dispensed by a specialty pharmacy, and most retail stores do not carry them. They'll have to be ordered. Current PA criteria has a low barrier to treatment. Our CCO approved greater than 90% of the requests that we received last year. Having a PA for expensive medication, even when the majority of requests will be approved, allows for stewardship of Medicaid benefits. PA review by CCO must be completed within 72 hours of receipt, and most PA requests by our CCO are decided within 24 hours, and this is 7 days a week, including holidays. If the idea is to improve access and resources for high-risk individuals, removing the case management requirement is not going to help. In our experience, our case managers are vital to helping the members access their medications, as well as access transportation, housing, and other barriers that they have for treatment. Our prescribers work with our case management staff to help members achieve a positive outcome. I encourage the P&T committee to consider tabling the proposal to allow for OHA to work with CCOs on improving access for members that need it while working within the current contracts risk corridor requirements. Thank you.
Thank you, Amy. Any questions for Amy? Great. We'll turn it over to Robin Traver. Robin, are you able to unmute yourself?
Yes, can you hear me?
Hear you loud and clear. The floor is yours.
All right, great. I'm Robin Traver. I am the Senior Director of Clinical Pharmacy Services for Umpqua Health. I would like to say that I believe that removing the case management and prior authorization requirement will be detrimental to our population. We rely on case management to improve the likelihood of treatment success. For example, we use care coordination, which is triggered by the prior authorization, to set up lodging for our members experiencing houselessness, which is a significant portion of our population that we're really targeting for treatment right now to try to eradicate it from our county. Additionally, we are required to respond, all CCOs as well as fee-for-service, we're required to respond to prior authorization requests within 24 hours. So this really doesn't delay the process, more than that 24 hours. Additionally, prior authorization is really needed to check for appropriate use. We recently in Douglas County recruited a significant amount of PCPs, our primary care providers, to start prescribing hepatitis C. And we really need to, ensure that it's being appropriately used. And then really lastly, the operational implications of this, some of the recommendations regarding only prior authorizing retreatment, that is very challenging to do from just a feasibility standpoint and what we have the capability to do for when we're programming edits to our medications. Additionally, the non-FDA approved indications, we cannot check for that unless we prior authorize this medication. And then lastly, I think if the committee does decide to remove the prior authorization requirement, I would request that we delay that to 2023 to allow some of these operational concerns to be worked out, and also collaborate with CCOs in other ways to maybe address some of these concerns as opposed to removing the prior authorization requirement. Thank you.
Thank you, Robin. Any questions for Robin?
Hey, this is Russ. I'm certainly sympathetic to the need to continue looping in case management, but you also mentioned being able to monitor for appropriate use, and I'm curious, do you have any data as to how frequently these are inappropriately prescribed?
I do not have any data currently. We just this year pushed out prescribing to our primary care provider community, who was actually quite hesitant to prescribe. They were a bit nervous about it due to, that they haven't prescribed for these medications before.
Yeah, I mean, that's generally been my experience, is that people tend to be, go the extra mile to make sure that they're certain before prescribing these.
I would expect we would have more data by the end of the year.
All right, thank you, Robin. Next, we have Dr. Douglas Carr. He's the Chief Medical Officer for Umpqua Health. Dr. Carr, are you able to unmute yourself?
I am. Thank you very much, Roger. I'm Douglas Carr.
The floor is yours.
I'm Douglas Carr. I'm Chief Medical Officer at Umpqua Health and work with Robin Traver. You know, when I looked at the written testimony and some of the verbal testimony concerning the importance of access to hepatitis C, DAA, I think that I agree with much of the importance of this access. All of the reference data is compelling, but expressions of virtue don't always translate directly into addressing reality. And I think that they reflect some naivety as far as health plan processes. Our goal at UHA is to ensure that all of our members receive and complete the course of treatment. And Roger hesitated with a direct question about how does a pharmacy request actually translate into notification to a health plan that care coordination is needed. And the real answer, the reason why he hesitated is he knows that it is not a direct, that you can't ensure that that actually occurs. And our experience at UHA is that this requires care coordination and support to truly complete the course of treatment. Our members need initial and ongoing education and coaching among our coordinators as well as our THWs. You know, some of our homeless, we have housed them. This last month, I've housed 3 homeless people in motels to ensure completion of their therapy. This is kind of a perk that we've offered. The safety of a $9,000 to $18,000 drug in a homeless shelter or a tent on the side of the interstate is very much in question. All care coordination requires PA as a notification. I think the 24 hours that it takes to agree is not the issue. We're approving almost virtually all of our PAs. We just need it as a notification. So when a prescription is written, it takes less than 24 hours to approve, but up to a week for the medication to arrive from the specialty pharmacy in most rural areas of the state. So I say that the PA process doesn't create the barriers to obtaining the drugs. It actually ensures completion of a course of therapy, which is the true goal. And I would again echo, this is not it's a great discussion today. I think the wise thing to do is to table this. There are enough questions about this that you need to loop in the CCOs because, as we know, the proposal only applies to fee-for-service pharmacy, but we all know that the CCOs will be held accountable to the same standard shortly. And we are under contract right now to do exactly what this eliminates. Thank you.
Thanks, Dr. Carr. And just to clarify, my hesitation is I can't speak for the CCOs, but from the fee-for-service perspective, we can see when claims are filled. So yeah, I can't speak for the broader thing, but the risk corridor certainly plays a role. So any questions for Dr. Carr?
When we say that the CCOs would be held to a similar standard, if we were to remove this PA for kind of the first line therapy, how exactly does that sort of standard get transferred to the CCOs?
You want me to
Great
respond,
question.
Roger?
Yeah, Dee, please.
It's in contract as part of the risk corridor. One of the things that CCOs are required to attest to is to follow the same PDL and PA criteria as fee-for-service, and to provide, I don't have the language right on the tip of my fingers, but to provide care coordination as agreed to in a document provided by OHA. And my hope is that the committee can focus on the clinical appropriateness and things that have been discussed about whether or not PA does create a delay, whether or not it's appropriate, conditions in rural parts of the states versus urban. I think all of those are important, and whatever is decided, it'll be up to OHA to figure out how to implement and when, and whether or not there need to be a change to anything in contract.
This is Tim, and I assume that the CCO contracts have a time period in which they apply. And if there's changes in fee for service, there's a time period in which the CCOs are contracted to apply to that. So it's already written for what CCOs say that they will do by contract, correct?
I'm sorry, what was, there would be, they would
Well,
be given.
we had two testimonies saying CCOs saying, hey, if we're going to move forward with this, let's wait till 2023 because we can't, it's going to be really hard on us. But I assume that there's contracted time periods already with our CCOs, and there's already language in those contracts saying they have X period of time to modify their practice to be within the fee for service. Is that correct?
Yes,
so they're
that's
already contracted to do whatever.
That's well, so for I don't know if I mean I don't know if I can answer about specifics about contract because I don't want to speak to that. I don't want to be I could get it wrong, right? We've made numerous changes in the middle of the year regarding hepatitis C, not as significant as this, but for whenever there's a change, CCOs are obligated to adopt that change, and we've provided 60-day notice in those cases.
Okay, so they have 60 days, 2 months to basically modify their practice if we do this change.
Well, that's how we've handled other changes. Again, they haven't been as significant. I don't want to say that they're the same, but that is the case. Yes, we would provide at least a 60-day notice. And if OHA decides that there's larger operational issues at play, then it could be longer.
Thank you.
Yeah, so then one of the questions that, so changing to the fee for service PA or lack of PA criteria would be more straightforward, but then with the case management deliverable that's required in this contract that ends in the risk corridor through 2022, it seems like those might be conflicting, and then CCOs would then provide a deliverable of case management that then drops precipitously, and so just unclear how that would affect the risk corridor and CCO accountability for case management.
And those are all things that should be considered by OHA probably separately from this. I mean, not saying that they're not intertwined, they are, but operationalization of what is deemed appropriate, especially when it comes to things like contract. I don't want the P&T to be bogged down with those kinds of concerns and instead focus on the other things we've talked about.
I hear what you're saying, Dee, but I also feel like, we have to consider the bigger picture of how the changes that we make will, the end result in terms of affecting the care that's provided to patients. And I mean, I'm all for increasing access to these medications and trying to eradicate Hep C. But I think, being mindful of the bigger picture is still important. And I'm curious though, I feel like I know the answer to this and that's why it hasn't been brought up, but would there be any way to use an auto PA to alert the CCOs while automatically approving the medications?
Again, 16 CCOs, different PBMs, they're going to have different processes. And, that's kind of outside of the scope here. We, fee for service, can, speak to our strengths or challenges within our own claims processing. But your point is taken, Russ. I mean, some of these things are outside of our ability to forecast. And so I think the comments we're hearing from the CCOs and the challenges they foresee with these proposed changes are what are being considered. And your comments, we're focused on fee for service, the PA criteria, PDL for fee for service. This is very unique with the risk corridor that it translates into coverage for the CCOs as well under the risk corridor. But for the broader considerations you're speaking to, I think are also being echoed by the CCOs. So appreciate that.
And I just want to clarify one thing. I didn't mean to suggest that the P&T should not consider the things being raised by the CCOs. I don't mean that at all. I was responding specifically just to what does the contract provide and that level.
There's a comment in the chat about carving out Hep C drugs, but my understanding is that would be a legislative act to carve those out the way mental health drugs are, and I don't think that also wouldn't address the issue of alerting CCOs to activate care coordination. If I'm not mistaken.
And I apologize, I'm trying to navigate chat, instant messaging, emails, and trying to make people co-hosts to provide public comment. So if I'm missing things, I'm trying to just stay on task with the next 6 people to provide public comment.
Right, and I think with the chat function, that can be difficult. I think our preference is for conversations outside of P&T members be reserved. Well, that they should be part of the public record and part of the public testimony. I appreciate that there's really good questions there, but that can
I do
make it
too,
hard
and
to
it just as a
navigate.
reminder, yeah, recommendations from this P&T committee go to the director of the OHA. Those recommendations are posted on the OHA's website, and there's an opportunity for people to question those, provide comment, and ask for reconsideration by the OHA, like within a week after that. So just wanted to remind people there's that opportunity as well, just as part of this process. Trevor?
I think you said it well, and I just wanted to underscore and call attention to what Dee was asking the committee to, really focus their attention on, not to minimize any of the operationalization concerns that were raised by the CCOs, but really the focus here today is to evaluate the evidence, evaluate what is before you as it relates to, hepatitis C treatment and the removal of PA as described, and make the decision. And then it's up to the OHA to take that recommendation, and we can choose to obviously there's a great deal of input that we have heard already. I think you said there's 6 more people, Roger. I don't want to take up any more time. And let's listen to the rest of the folks. And again, let's focus on the decision before you. And I understand that there's certainly operational time concerns and timeline concerns that have been raised. And those are valid concerns that OHA should consider. So but I think separate from what we're asking the P&T committee to look at.
And I may have exaggerated. It looks like I have 4. So next, we'll turn it to Kate Jeline with Arden. Are you able to unmute yourself?
Yeah.
The floor is yours.
Thank you. Hello, I'm Kate Jeline, Director of Programs and Outcomes at Arden Health Specialty Pharmacy, located in Portland, Oregon. So today I just wanted to share some insights from a specialty pharmacy perspective on this topic, as we feel it's an important step in reducing the administrative burden on both the pharmacy, the clinic, the health plan, and ultimately the patient. So pharmacies track the speed in which a prescription is filled, often called speed to therapy. When we look at the average speed to therapy for these DAAs, a clean prescription, which is one that does not require a PA, takes on average 3 days. In comparison, a prescription for a DAA that requires a PA takes an average of 7 days. So there is an increase in time that it takes for the prescription to be available for the patient. So while this adds a few additional days, the greater challenge is the additional touch points and communication that's required to facilitate the prior authorization. We've seen this lead to patients being confused and often discouraged as they see the PA as a negative barrier when they already have a lot of negative barriers to overcome. In addition, the time devoted to the administrative burden seen in the clinic and the pharmacy could be much better spent providing care to these patients and supporting them to success. Specialty pharmacy has clinical programs to support these patients and is uniquely positioned to be helpful in ensuring treatment-naive patients are connected to case management. I also looked up some metrics while some others were commenting, and I did see that for the year of 2020 and 2021, we only saw one DAA denied for PA on that one. And I also looked, there's a lot of different metrics that we look at, conversion rate, cancellation rates. And I looked back to see how many prescriptions were canceled. So a prescription that arrived to us that the patient never filled. And there were more canceled prescriptions on prescriptions that required a PA for DAAs than prescriptions that didn't. So not, a lot of metrics to kind of show a little bit that we're not seeing, any negative impact from our side on a patient that did not require a PA. If anything, it was the reverse. And that's all that I have.
Thank you, Kate. Any questions for Kate and the perspective from a specialty pharmacy filling these meds?
Thank you. That was a good insight.
I was curious about earlier testimony said that they respond to all of these within 24 hours and that delays are typically caused by acquiring the drug. I'm curious what your thoughts are on whether that's would explain the difference in the speed to treatment that you were describing.
Yeah, I mean, in reality, it's going to add a few days, but I don't think that the time is necessarily the barrier. It's the tasks that fall within that time. So the amount of phone calls that they need to receive, which can be challenging for patients who are homeless or living in a shelter. So there's a lot of other extra challenges that can be added onto it. So it's not necessarily the days, it's the work that has to be done in those days.
Other questions for Kate? All right, thank you. Next, we have Lauren Sant. Lauren with Caring Ambassadors. The committee should be familiar with Lauren. She's provided impassioned public comment previously. Are you able to unmute yourself, Lauren?
I have. Thank you, Roger. I really appreciate it. And thank you, everybody, for being here today and taking on this subject. I'm Lauren Sant. I'm the Executive Director of the Caring Ambassadors Program, and we're a national nonprofit that does education and advocacy for people with lung cancer and hepatitis C. I do get funding from Gilead and AbbVie and Merck, although they have not been paid to testify today, just to be clear. I really want to thank you, first off, for removing all the previous restrictions that have been in place. As you know, Oregon started off with some of the most restrictive policies in the country. And because of these changes, we really have increased access to care. And we, prior to COVID, were on the road to eliminating hepatitis C by 2030 as a public health threat. And a lot of that is because you've increased access. And this is the final barrier that really is a barrier for patients. And I'm listening to these comments, and while this is the national standard for treatment for patients to get treated right away, what I'm hearing is logistical things. And I just want to say, I am sure that the Oregon Health Authority and the CCOs can come up with another trigger that would encourage case management. I haven't heard anything on this prior auth that's saying you should not do case management. So I'm sure you guys can figure that out. And I just want to thank you, and your vote today to remove this will save lives on our poorest and most needy and most challenged patients. And so again, I just want to thank you for everything you're doing, and please vote yes to save lives in Oregon, and let's cure this disease. You won't have to hear from me anymore. Let's eliminate this disease by 2030 in Oregon. And thank you. I'm going to leave you time, Roger.
Appreciate that, Lauren. Sorry, I was on mute. Any questions for Lauren? All right, thank you. Next, we have Dr. Andy Seaman. He's assistant professor with OHSU, Old Town Clinic, and also Central City Concern. Andy, are you able to unmute yourself?
I am. Thank you, Roger. And thank you, members of the committee. I have to say, when Dr. Orager said that he supported this, I started to cry. So I've also been this. with this since 2017, since the beginning of all of this, and we've had a number of conversations. And I, like you said, I'm the medical director of hepatitis C, the hepatitis C elimination program at Central City Concern, which was ranked the top 3 elimination programs in North America. And I have been watching this prior authorization process be an impediment to care for those 5 years. And I have watched people feel stigmatized by this prior authorization process and feel not worth it and not worth the money that these medicines are cost. And I have watched the data just pile up and how this can be done, and wished that I could use some of the tools I have at my disposal to be able to do this on the spot, treat people immediately, get this disease eliminated. We have treated something like 1,500 people now in the last, mostly the last 3 years, and we've had about a 92% of the people who come into our system get treated. And we do that through a lot of systems that navigate around the prior authorization that most clinical settings do not have the ability to do. That is the ability for us to get around the prior auth is why we are able to do this. And most systems cannot do this. I'm also the director of the hepatitis C elimination echo and have been for several years. I've watched the prior auth be a barrier to care for literally hundreds now of providers. I have heard these stories of the prior auth being a barrier. And I also run an NIH funded study looking at telemedicine treatment of hepatitis C in rural Oregon, and I've seen it be a barrier over and over again. And so with all due respect, Dr. Traver and Burns and Carr, we've worked together before, and I have respect for you, but we as providers are responsible for caring for these people and getting these medicines out and curing hepatitis C. And I know you have an important role in care, but I'm just telling you that to hear that it's not a barrier, I just is absolutely not true. Now, I'm not saying that you don't have that experience, but it is just not true. And you've had 6 months. I know you can do this. I've had conversations with Care Oregon. They feel like this is possible, and others. I think the key is that I think there are plenty of ways we can adapt to the case management considerations, including opt-in systems for people who need care, including if you are still worried about, if you're worried about some of the contractual issues, outreach post-treatment when you identify a medication has been prescribed. And so, and again, there are going to be different systems, as Roger mentioned, for different CCOs, but you can figure this out, and it is absolutely a barrier. And we will be able to do so much more if we get rid of this prior authorization. And I just want to say, thank you to all the P&T committee members who have stated, I realize I'm out of time, but this has been a 5-year journey, and I'm going to wrap it up. But we need this. We need this, and it absolutely impacts care. And I have seen it impact individuals that we have lost to follow-up and that were lost. And I don't know how many people they transmitted hepatitis C to afterwards, but we need to move past this. And so with that, I'm happy to stay and take questions. The time is now. Let's not table this again. The time is now.
This Bill Royer, got a question. How would you, in the absence of PA, how would you trigger the case management to make sure it gets done?
So I think there are a lot of different ways. My experience in working with ECHO providers, as I think was brought up. So ECHO, again, is a model of training people to do complex things like, well, it's not actually that complex to treat hepatitis C now, but training people to do new things from a specialized environment to rural environments largely. And people are hesitant to treat people, in part because of the prior auth process, but in part because of this sort of perceived exceptionalism. And they also want support. So if people know that they can get case management support for their chronically homeless patients, for all sorts of other complicating factors, mental illness, they will absolutely ask for it. I mean, it will be the CCO's jobs to communicate that to them. And I would recommend backup systems. But most people, if they know it's available, will absolutely reach out for case management support, even at the time of screening people or positive hepatitis C RNA values. And most CCOs have some system, like I even saw a comment, you may have to run a claim every day. That does sound onerous. And we're talking about lives here. And And so I would say that we'll have to figure it out, and you'll have to figure it out in your individual systems, but I'm very confident that you can. And this is not a surprise. We've been talking about this for the last 6 months. And so I really encourage you to get creative. And I am happy to work with any of you to troubleshoot some of these things in anywhere. So reach out. There are plenty of other people who would as well, but we can figure this out. Let's do the right thing, and let's get people treated.
Thank you, Andy. Thank you, Bill. Other questions for Andy? All right, I appreciate it. Our final public comment, I believe, I'll go check my emails in just a moment. Ann Thomas, Director with Public Health, Physician with the OHA. Are you able to unmute yourself?
I am, thank you.
Absolutely, the floor is yours.
Thank you, Roger, and thank you for allowing me to speak today. I'm a public health physician at OHA, and I oversee our viral hepatitis prevention and surveillance program. And I can tell you from a public health standpoint, removing the prior authorization requirement for use of HCV direct-acting antiviral agents is an important step towards eliminating Hep C in Oregon. Prior authorization requirements place a big administrative burden on providers. Dropping the requirement will make it more feasible for primary care providers to care for patients with HCV. The requirements are also a barrier to initiating treatment at the first contact with Oregonians who are the hardest to reach, persons who inject drugs, and those who are houseless, which are often co-occurring conditions. These vulnerable Oregonians represent a highly stigmatized and marginalized population, and they can be difficult to engage in treatment. Any steps we can take to streamline office procedures and reduce administrative hurdles will increase the numbers of people who can take advantage of these medications. In Oregon and the US, we know that the prevalence of Hep C is highest in baby boomers, and we've made great strides in Oregon in treating this group since 2015, when direct-acting antiviral medications became available. Based on some modeling results from an analysis conducted in 2019, Oregon was on target to reduce the prevalence of Hep C by 90% by the year 2030. But we're facing a new wave of cases in young adults. The highest rates of acute Hep C occur in people aged 20 to 29, and the rates of newly diagnosed cases of chronic Hep C in persons under the age of 30 have also been climbing. Cases in young adults most commonly occur in people who are actively injecting drugs and who are at the highest risk of transmitting the infection. Just as we did successfully with HIV, we have adopted the strategy of treatment as prevention, which aims at targeting treatment for those most likely to transmit the infection to others, as an important component of our elimination strategy. And unlike baby boomers, where cases are more common in males, half of Hep C cases in young adults occur in women of childbearing age. It follows then, by treating more young women with Hep C, we can also potentially decrease the rate of perinatal transmission in Oregon, which is rising. Lastly, I would like to emphasize that we are not opening the floodgates. In 2019, based on all payroll claims data, just over 4,000 Oregonians initiated treatment for Hep C. Our modeling data suggests we need to treat between 3,000 to 5,000 Hep C patients a year between 2020 and 2030 to meet WHO goals for eliminating Hep C. These numbers are very feasible. We got to 4,000 by dropping restrictions based on sobriety and fibrosis scores without overwhelming providers and healthcare system. Today's proposal to drop all prior authorization requirements will simply ease the administrative burden of treating patients who are at the highest risk of spreading Hep C. So if we can restore rates of treatment to pre-pandemic levels and focus more efforts on treating those who actively inject, Hep C elimination is within reach. Thank you.
Thank you, Dr. Thomas. I want to open it up to questions for the committee for Dr. Thomas. No questions? All right. Again, thank you, Dr. Thomas. Yeah, we're going to go back now to revisit the recommendations that are in front of the committee. Again, we had proposed PA criteria changes in front of the committee. but we kind of think this is kind of a twofold decision. So we probably should take the first recommendation, which is remove PA criteria and required case management for preferred DAA regimens for treatment naive patients with Hep C virus. Questions about that?
So we're removing the mandate for case management, or we're saying that case management isn't required?
Correct. The latter, Bill, that for the preferred agents for treatment naive, we would remove that PA requirement, which would encompass case management for it as well. Wouldn't mandate it.
So we're removing the PA, but then case management can still be available through other means. It's just that we are no longer policing it.
Correct. That it wouldn't be part of, I mean, currently within the current criteria, we ask the question before we even get to is it preferred or non-preferred, will the provider and patient comply with all case management? If we are removing a PA for a preferred regimen for someone that appears to us to be treatment naive based upon their lack of any claims in the history that we can see in the system, it would not require that case management. Nonetheless, we still have the ability to look for those triggering claims, pass it on to case management, and engage the members to see if they can be assisted with filling the scripts, completing their treatment regimen, and ideally collecting that SVR.
You know, there's a number of complex things that we prior auth that require case management that we don't mandate. You know, you look at the thousands of joint replacements that are done every year. That requires an incredible amount of coordination and aftercare. But insurance traditionally says, do you need the operation? Yes, no, and you're done. And then the hospitals and medical groups have pretty much stepped up to the plate to fill in the blanks. Could we
Agreed. And
make a comment on this where we approve eliminating prior authorization for treatment naive, but we urge the Oregon Health Authority to work on implementation of this to ensure everything's done to help the patient get the treatment. I don't know whether you want to use case management or not, but the facilitation of treatment still has to happen, but I don't think it has to be triggered by the PA.
Yeah, I mean, running a report daily seems like a fairly low hurdle on the side the side of an insurance company, compared to delaying treatment in situations as Andy Seaman and mentioned. So, I mean, I feel like the PA is not a significant hurdle. If there are other ways that they could get the information, by running a report.
Appreciate it, Bill and Russ. Others?
Would entertain a motion?
Motion to approve.
Second.
I'll second.
All right. All those in favor?
Aye.
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 Any abstentions? Any opposed?
I'll abstain.
Pardon me, Kat, what, tell me, are you opposed, Kat?
I'm abstaining.
Abstaining, okay, so noted.
Great, and so the second part of the recommendation is to continue to require PA. This would be for retreatment or non-preferred agents or uses that are not approved by the FDA. And that was kind of gone over by Megan with the proposed criteria. Questions about that or a motion?
Motion to approve the
Or
PA criteria for non-preferred and treatment experienced.
Thank you, Eddie.
Second.
Okay, it's been moved and seconded. All those in favor?
Aye.
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 Anyone abstaining? Anyone opposed? Onward.
And then the last part of the recommendation was to make sofosbuvir, velatopir, valacyclovir, which is Vosevi, which is really indicated for retreatment, to make that a non-preferred agent on the PDL. It already required PB before, it'll require PA going forward, but just to not call it out as a preferred treatment regimen. So make that non-preferred. Need a motion on that one as well.
So moved.
Thanks, Robin.
Second.
Oh, all right. All those in favor?
Aye.
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 Abstain? Oppose? Okay.
Fantastic. Is there anybody else, any hands raised in the public that I didn't call? Again, I've been trying to toggle between multiple platforms to make sure I didn't miss anybody and things were coming in moments before we recognize this class. Just wanted to again reiterate that recommendations from the committee will be going to the OHA. They'll be considered, generally posted within a week, and that there's also opportunity to follow up on that to provide additional comment to the OHA for consideration. So I think that's important that everybody realizes. So particularly in this case, as we have the risk corridor, and it's unique that fee-for-service and the impacts on CCO. So I really appreciate everybody's participation. Moving forward, the next topic on the agenda is sickle cell disease. It's a literature scan. Draw your attention to page 46 in the packet of materials, and we'll turn it over to Kathy Centena.
Great, thanks, Roger. So a little background on this class. We did a literature scan just to evaluate any new literature out there and evidence, and to determine if prior authorization criteria changes are needed in response to expanded indications for drugs in this class. The previous policy was that we designated hydroxyurea capsules, the generic formulation, as preferred, and then the other products in the class, voxelotor, crizanlizumab, and L-glutamine, as non-preferred. As a whole, there's very low utilization in this class, and all the claims have been for hydroxyurea. And just kind of as a reminder, hydroxyurea is first line for the treatment of sickle cell, with the other drugs in the class used for pain management and reduction in vaso-occlusive crisis, as well as some other issues. We did have just limited evidence for this class as it was reviewed in June of 2020. There was one new NICE guideline that came out on the use of crizanlizumab, which did support our current policy. So looking at a couple new indications for the class, the first is for voxelotor, brand name Oxbryta. It received an expanded indication for the use in pediatric patients 4 years of age and older with sickle cell disease. This indication was based off of data from patients in a small open label, so 45 patient single arm phase 2 trial. Most of these patients, around 80%, were also on stable doses of hydroxyurea. The trial did demonstrate that 36% of patients did experience an increase in hemoglobin of 1 gram per deciliter or greater from baseline to week 24. Now, this increase in hemoglobin is often measured and used for efficacy determinants for drugs for sickle cell, but specific levels haven't been correlated with health outcome benefits such as mortality, stroke, and end organ damage. However, there is limited evidence that this change of 1 gram per deciliter or more does decrease the rate of multi-organ failure and death. Moving on to the next slide, there's another new indication for hydroxyurea, the brand name Cyclos, and it received an expanded indication for the use in adult patients to reduce the frequency of painful crisis and to reduce the need for blood transfusions in those with sickle cell with recurrent moderate to severe painful crises. This indication was based off one observational phase 4 cohort study in around 2,000 adults. The outcomes that were looked at in this study were changes in vaso-occlusive crisis lasting greater than 48 hours, acute chest syndrome episodes, hospitalizations, and the percent of patients requiring blood transfusions within the first 12 months. And then, so this group was compared to the previous 12 months. And what they did find were that most of these outcomes, or all these outcomes, were reduced with treatment with hydroxyurea. Most significantly is the last outcome, where the number of patients that required at least one blood transfusion was reduced by 223 patients in the hydroxyurea group. Moving on to some safety updates for this class. There's a couple for hydroxyurea. One is for hemolytic anemia, and patients should be monitored for any kind of acute jaundice or hematuria in the presence of worsening anemia. And then the second one is for secondary leukemia in those that have been using hydroxyurea long-term. And so again, these patients should have regular blood counts performed to monitor for any kind of leukemia indicators. And then lastly, crizanlizumab. There's been reports of infusion-related reactions and a warning and precaution added to the labeling that include these reactions causing severe pain and potentially hospitalizations have been reported. So again, patients should be monitored, and potentially crizanlizumab should be discontinued if the reaction is severe. So then I'd like to direct your attention to page 51 in the packet, which goes over some changes to the PA criteria. So you can see there in numbers 1 through 4, standard kind of wording. Number 4 is asking if this is for renewal requests, and then directing them to directing individuals to the renewal criteria, which we'll talk about in a minute. So looking at number 5, just a clerical modification, adding the word formulations there with preferred products. Number 6, again, just clarifying the wording. This isn't any change in policy. It's just, again, try to make it a little bit more clear, asking if the patient has failed a 3-month trial of hydroxyurea at stable doses or have contraindications to hydroxyurea. So number 7, going on, here's the change, accounting for the expanded indication for those patients requesting voxelotor, in that if asking just that they're 4 years of age or older. And then another verbal change I wanted to add in here to number 8, it asks, does a patient have a hemoglobin level of 10.5 or less and have a history of at least one pain crisis in the last 12 months? And this was included because in the trial looking at voxelotor in adults, this was one of the inclusion criteria. However, in the Hope Kids trial that looked at the expanded indication for pediatrics, this was not a requirement. And therefore, I also recommend that we take this out and just have the requirement of hemoglobin levels. And then number 9 to 12 there's no changes for those. So then looking at the renewal criteria, just asking if the request is for a first renewal of voxelotor, and then if yes, asking if the patient had an increase in hemoglobin from baseline. If so, approve it for 12 months. Number 3 is if this is for subsequent renewals of voxelotor, and if so, if just those hemoglobin levels have stayed stable over time. And then number 4 is in regard to crizanlizumab, just asking that the patient has had demonstrated improvements from baseline, and we could put pain improvements in pain symptoms to be a little bit more specific. We just wanted to change the wording slightly to ensure that patients that receive some improvement were still able to receive crizanlizumab. And then number 6 is asking about L-glutamine. And again, just kind of clarifying that wording to assist in applying the criteria to asking if the patient has a reduction in at least one annual pain crisis from baseline. And if so, to approve it up to 12 months. So the recommendations for this class is to no changes to the BDL based on the evidence review, but to update the PA criteria with those expanded indications, as well as some of those clarifications to the PA criteria, and then evaluate costs in executive session. Are there any questions or can I clarify anything further?
Great job, Kathy. Yeah, questions for Kathy?
Maybe just a couple thoughts on the wording of some of the lines, like line 6, approval criteria, the quote, failed a 3-month trial. I think failure might be hard to really define. Maybe you could just say like received a 3-month trial, and they should probably be remaining on Hydrea. That would be my one thought. And then I have a second thought, line 7 of the renewal criteria. Maybe just like make that the same as line 5 and just keep it like, have they had any improvement, rather than kind of using the arbitrary 1 annual pain crisis reduction. Like line 7 just feels kind of more elaborate than it needs to be.
Okay, yeah, I think those are great suggestions.
Is there a standard in studies about treatment failure, like how they define that?
Not necessarily. It's just more that the patient continues to have pain or crisis related to sickle cell, although it's not strictly defined as, not strictly defined.
So I'd recommend either removing the failed or being specific. What is a failure?
Yeah, there's like immense heterogeneity between studies of how they define like severe disease or like kind of refractory to Hydrea. So I think it'll be hard to concisely and accurately define.
I don't know of any standardized tool for assessing that.
Yeah, those are great recommendations. I can definitely change that wording to make it a little bit more clear and appropriate.
Other questions or thoughts for Kathy? We do have public comment. All right, we have Centuries Booz from Global Blood Therapeutics. I hope I got your name right. I apologize. Are you able to unmute yourself?
I am, and you said that perfectly. Thank you so much.
Oh, you bet. The floor is yours. You have 3 minutes to address the committee.
All right, thank you so much. My name is Centuries Booz. I'm a managed care liaison with Global Blood Therapeutics. We would like to thank you for the opportunity to provide comment on the current Voxelotor criteria. We would like the committee to consider removing the pain crisis or vaso-occlusive crisis, also known as VOC requirement from the policy, to align with our most recent clinical trial data, and that as previously stated, is prior authorization criteria question 8, which does require patients to have a history of at least 1 pain crisis in the last 12 months. As previously stated, our Hope Kids 1 trial did not require the children to have a VOC in the previous 12 months in order to enroll in the study. 21 patients, or about 46.7% of the Hope Kid trial participants, did not have a VOC in the past year. The annualized incidence of VOCs was evaluated as a secondary endpoint in the phase 3 pivotal HOPE trial. Those results provided reassurance that Voxelotor treatment could safely raise hemoglobin without causing a viscosity-related increase in the risk of VOCs. The HOPE study was not enriched nor powered to evaluate VOCs as an efficacy endpoint. Although VOCs are a common complication of sickle cell disease, one retrospective study of patients with SCD showed that 52.3% did not have any VOC episodes over a 12-month period. The FDA labeled indication for Oxbryta does not include a requirement for having a VOC prior to initiating treatment with Voxelotor. Voxelotor inhibits hemoglobin S polymerization, which is the root cause of sickle cell disease pathology. And patients who suffer from anemia and hemolysis can still benefit from Voxelotor regardless of the number of baseline VOCs. So we do want to thank you for your time and consideration. I am available to answer any questions if there are any from the committee.
Thank you, Dr. Booz. Any questions? Okay. So again, reminding the committee of the recommendations in front of you. I don't know if you have any more dialogue or questions for Kathy. recommendation is no PDL changes based on the clinical evidence, and to update the PA criteria as proposed and amended by the recommendations from this committee. And then we'll evaluate costs in executive session.
Do we have a motion?
Motion to approve.
Second.
All right. All those in favor?
Aye.
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 Okay, anyone abstaining? And all those opposed? Okay, passes.
Fantastic. Well, I propose at this time we're a little behind schedule. Not surprisingly, we had quite a fair bit of public comment, that we go for break for 15 minutes, if that works for the committee. I will reset the timer and we'll reconvene at 3:05. Does that work for the committee?
Yes.
Yes.
All right. We'll see you in 15 minutes. Thanks, everybody. Okay. Hope that was an adequate break for the committee. Just want to make sure that we have the committee all back. I see, before we do a handoff, just looking down the committee list to make sure everybody's there. All right, let's proceed. We have a bit of an agenda to get through still. If you're following along on the agenda, the packet of materials posted on our website, direct your attention to page 54 for the Fabry disease literature scan, and we'll turn it over to Deanna Moretz.
Thank you, Roger. I didn't put together a PowerPoint for this this lit scan, mostly because the literature scan was initiated because Fabrazyme, or agalsidase beta, received expanded FDA approval in last year, March 2021, for patients age 2 and older with confirmed Fabry disease. And prior to that, the manufacturer's label stated that it could be used in children that were 8 years of age and older. So if you recall, the last time we reviewed Fabry disease was in 2019. Fabry disease is a metabolic disorder that is a lot of times identified in children because they can't metabolize certain enzymes that they're missing. It's a genetically inherited disease. So the two drugs that we have to treat this are agalsidase, which is IV, it's administered intravenously, and then migalastat, which is oral. But in order to be eligible for migalastat, the patient not only has to have Fabry disease, but they also have to have a confirmed variant of Fabry disease that makes them eligible for that. So if you scroll down to the bottom of the page, you'll see we had about 60 patients under the Oregon Health Plan that have Fabry disease. 3 of those were enrolled in fee-for-service. Most of them are enrolled in CCOs. All of the claims that the CCOs received were for the physician-administered claims for agalsidase. We haven't had any claims in the past 12 months in either fee-for-service or CCO for the oral drug. So the evidence for the expanded approval There is not a published study. I had to look at the package insert to figure out why the FDA extended the approval. Basically, what I could find is that they extrapolated the evidence from adults into the pediatric population. There was one study that was conducted in kids that were 8 to 16 years of age. And then they have some additional data, which was published in 2006 in 24 pediatric patients. So the FDA approved the request by the manufacturer to expand the age. So that resulted in a change in our PA criteria, which thank you, Sarah, for scrolling down. So right there, the biggest thing is we used to have is a patient 8 or older if they were going to be getting a galsidase beta. So we just changed it to be 2 and older for number 10. And then if they're female with document and they're a carrier and they have genetic testing that shows that they have manifestation of the disease, those were the only changes that we made to the PA criteria based on the expanded FDA indication, FDA approved indication. So the recommendation is to modify the PA criteria to align with the FDA approval. Any questions from the P&T committee based on the split scan? There was no new high quality systematic reviews or guidelines that have been published since the last update.
Thank you, Deanna. Questions for Deanna?
Do we have any public testimony?
We do not, Bill.
Okay, so motion to approve?
Kimmel motion.
And a second?
Second.
Second.
All right, all those in favor?
Aye.
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 Anyone abstaining? All those opposed? Okay.
Great. Moving on, draw your attention to page 62 in the packet of materials. We'll turn it over to Dave Engen.
Thank you, Roger. So today we'll be discussing a new drug evaluation for vosoritide, trade names Voxzogo, for the treatment of achondroplasia. So first, a brief background. So achondroplasia, it's a skeletal dysplasia. It's caused by gene mutation on chromosome 4 and results in disproportionate growth and small stature. There are other potentially serious complications that are exhibited in people with achondroplasia. May lead to things such as hypotonia, spinal stenosis, respiratory dysfunction, and obesity, just to name a few. So it affects roughly 1 in 25,000 births. And although claims data from 2021 OHP population identified 55 individuals with the diagnosis, about 15% of those were fee-for-service, and it's unclear how many of those were children versus adults. So vosoritide, it's a CNP analog. It's designed to target the signaling mechanisms that regulate bone growth. And it's approved for treatment of achondroplasia currently in pediatric patients who are 5 years of age and older with open epiphyses. And the clinical efficacy, or take a look at the trial. So it was investigated in a 52-week phase 3 double-blind randomized controlled trial, and they compared that to placebo. The patients were relatively young, obviously, between 5 and 15, mostly Caucasian, with the baseline annualized growth velocity, or AGV, around 4 centimeters per year. They were ambulatory patients. There are plenty of exclusions, as you can see, and most of those were based on comorbidities and things like bone surgical history and things of that nature. The primary outcome that they studied was a mean change in AGV. And at 52 weeks, there was roughly a 1.5 centimeter difference from the baseline rate observed in the vosoritide group compared to placebo. As far as trial limitations, there were some to note. The age range studied was, like I said, about 5 to almost 15 years. So we don't know treatment effects for those outside of this range. We also don't know much about the effects of the drug in other clinically significant areas, such as spinal height, proportional growth, functional improvement, and things of that nature. Plus, the long-term medical complications weren't studied. So many of the health issues that people with achondroplasia may experience, annualized growth velocity may not be the most important endpoint. So those were a few. Looking at the clinical safety, over the 1-year trial period, it was noted that many patients experienced injection site reactions, vomiting, arthralgia, hypotension. I'd refer to the write-up in your packet for the relative percentages. It's table 2, I believe. There's also a warning for the potential of worsening hypotension if taking other blood pressure agents. And it's not recommended to be used in patients with kidney dysfunction, or more specifically, GFR of less than 60. So let's take a look at the PA criteria. So first off, we start off with pointing out appropriate dosing. You can see that in table 1 there. The actual criteria itself is fairly straightforward. We ask for diagnosis, and we stick to the FDA labeling. And go down to number 6, we want it to be prescribed by a specialist. Number 7, request baseline measurement and basically evidence that the growth plates haven't fused. 8 and 9 are safety questions to make sure the drug has a chance of working, not causing harm. So if you look at the next page on the renewal criteria, it's also fairly straightforward. Basically we're asking, was the drug tolerated? Did the patient take it routinely? And is there evidence that it actually worked? So that is about it. So the recommendations, since we're not planning to assign a PDL status because it's currently not in a class, the recommendation of the committee is to implement prior authorization criteria for vosoritide to ensure appropriate use. And that should do it. So questions?
Thanks, Dave. Questions for Dave?
Do we have public comment, or is it time for a vote?
Sorry, I'm talking to myself here, Bill. Thank you, Dave. Great job. I was going to ask if there are any questions. We didn't hear any. No public comment. So the recommendation in front of the committee is to implement the proposed PA criteria to ensure appropriate use. Just need a motion.
So moved.
Seconded.
All right, all those in favor?
Aye.
Aye.
Anyone abstaining?
Aye.
Is that one abstention, or is that an aye? Yes. Okay. Anyone opposed? Okay, done.
Okay, moving on. Draw your attention to page 76 in the packet. I have a new drug evaluation, and we'll turn it over to Kathy Centena.
Great, thanks. So today we're going to be looking at efgartigimod. This is a drug that was approved in December of 2021. And It works by affecting the neonatal FC receptor blocker, which reduces IgG subtypes without influencing other concentration of other immunoglobulins. So it helps to decrease IgG antibodies. And these IgG subtypes have been translated into improvements in myasthenia gravis symptoms. And that is what this drug is indicated for the treatment of generalized myasthenia gravis in patients who are acetylcholine receptor antibody positive, which is approximately 85% of the population with myasthenia gravis. This is an infusion, which is given about over an hour once weekly every 4 weeks. Just kind of as a general review, the standard of care for myasthenia gravis is to provide symptom management with acetylcholinesterase inhibitors such as pyridostigmine, as well as many patients do require chronic immunosuppressive therapy with glucocorticoids, as well as nonsteroidal and immunosuppressive drugs such as azathioprine and cyclosporin. Short-acting agents are also used. Those immunomodulating treatments are therapeutic plasma exchange and intravenous immune globulin when more of a rapid onset type treatment is required. Just to give you a little perspective, there were 44 patients last year diagnosed with myasthenia gravis in the fee-for-service population, and we only had 3 claims over the year for FDA-approved myasthenia gravis treatments. So looking at this drug in particular, approval was based off of one double-blind placebo-controlled randomized trial that lasted 26 weeks. There were 167 patients enrolled, in which 71% were female, 47, or the mean age was 47 years, and 85% were white or Caucasian. The major inclusion criteria for this study were adult patients 18 years and older that had generalized myasthenia gravis, and these were categorized based on the myasthenia gravis activities of daily living scale. So what this does is it evaluates the impact of myasthenia gravis on daily functions and basically signs and symptoms that are associated with weakness, things like that, with myasthenia gravis. And it's a scale in which goes from 0 to 24, and then patients are classified based on disability. So what it looked at for inclusion criteria is that these patients had to have a score of at least 5, with greater than 50% of those symptoms being non-ocular. They had to be on a stable dose of one treatment for myasthenia gravis, such as acetylcholinesterase inhibitor, steroid, or an SIST. So 76% of these patients were on a steroid, 61% were on an nonsteroidal immunosuppressant therapy, and then 80% were on acetylcholinesterase inhibitors. Exclusion criteria were other drugs used for myasthenia gravis, thymectomy in the recent history, so in the previous 3 months, as well as medication that could cause weakness or aggravate symptoms or weakness due to infection. So as many of you know, with myasthenia gravis, medications can often trigger symptoms or and worsen symptoms of myasthenia gravis. So these were excluded. The primary outcome for this disease was myasthenia gravis activities of daily living responders in cycle 1 that were positive for the acetylcholinesterase receptor antibody. So this was defined as, a responder was defined as a 2 or more point reduction in this scale compared to baseline that was maintained for 4 consecutive weeks, with the first reduction occurring no later than the first week after the last infusion. So basically in cycle 1, so response in cycle 1. And 66.7% of patients did complete this cycle. And a note too that 2-point reduction is also considered the minimal clinically important difference. And so that made sense that that was what was considered as a responder. So we can see there that 68% of patients receiving efgartigimod did have a response compared to 30% of placebo-treated patients. Looking at limitations, of course, this was just one trial that was fairly small of short duration that efficacy is based on. Also want to note that there was a higher incidence of thymectomy in the efgartigimod group. So 69% of patients receiving active treatment had a thymectomy compared to 47% receiving placebo. And this could infer an advantage as these patients do usually experience less muscle weakness and need for immunosuppressant drugs. Additionally, most patients were on background therapy as noted in the inclusion criteria. For safety, you can see that common, adverse reactions occurring, some expected for this disease state. So respiratory tract infections, headache, UTIs, paresthesia, and myalgias were higher than efgartigimod treated patients. Serious adverse reactions were 5% in efgartigimod patients compared to 8% placebo, and discontinuation rates were similar between the groups with 4% in both active and placebo treatment. Looking at then the PA criteria, which is recommended for this therapy, I'd like to kind of step through that briefly. This does start on page 85, if you would like to go through it in your packet. So what we're asking here in questions 1, 2, and 3 are kind of the basic questions: what's being treated, if it's a FDA approved indication, and if this is a continuation of therapy, we're directing individuals to go to the renewal criteria. But if not, number 4, asking if it's a funded diagnosis by OHP. If yes, go to number 5. Asking that this is request is made by a specialist, either a neurologist or rheumatologist. If yes, go to number 6, asking if the patient has an active infection, since this does interfere with IgG. If they do, denying therapy, but if no, then go to number 7, asking if the patient's received the appropriate immunizations or have contraindications to them, just because immunizations are recommended before treatment and not during, especially for live viruses or live or attenuated vaccines rather. So if they have all the required immunizations, go to number 8, asking if the patient has that they are positive for serological tests for the anti-acetylcholine receptor antibodies. If so, go to 9, asking if the patient has a myasthenia gravis Foundation of America clinical classification of 2 through 4, which just indicates mild to severe disease, and that's who is enrolled in the trial. If yes, go to 10, asking if the patient has MG-ADL score of, it should be 5 points or more, so that's just a typo, need to remove the 6. If yes, go to 11 after recording that baseline score. And then here we ask that the patient has received or is currently receiving at least 2 immunosuppressant therapies as monotherapy or in combination, which is all appropriate, that they've had a trial of these for at least 1 year, because a lot of times the onset of these are, you do take months, or that they have contraindications to these. So an example are some of those therapies I noted earlier, such as azathioprine, cyclosporin. You can read them there. And then if yes, if they've done those trials, go to 12, and then just asking that they're requesting a dose that corresponds to labeling, which is 10 milligrams per kilogram up to 120, and then 120 more, just the recommended dose is 1200 milligrams per infusion. If so, then approve 2 cycles of treatment separated by at least 50 days, as again recommended in the labeling. And then if the request is for renewal criteria, we go to the next slide, just again asking that it's been at least 50 days or more from the start of the previous treatment cycle. If yes, go to number 2, asking if this is the very first renewal. If so, go to number 3. And here we're just asking that they experience a reduction in symptoms of at least 2 points as defined in the trial, as well as the MCID for that outcome. If so, approving up to 5 cycles, which would allow for about a year's worth of therapy combined with the other 2 cycles that they already received. If this is for subsequent requests, then we ask the patient goes to number 4, and that the patients they have just maintained a stable MG-ADL score over the last 12 months of receiving therapy. And if so, then to approve up to 12 months of treatment, which is 7 cycles. So that's the PA criteria. So the recommendation for this drug is to designate it as a non-preferred therapy on the PDL and subject to prior authorization criteria. And I'm happy to take any questions or comments.
Yeah, thank you, Kathy. Questions? No public comment. Recommendations are to designate as non-preferred on the PDL and subject to the PA criteria that was just walked through, and to designate as non-preferred and implement the proposed criteria that was just reviewed.
Okay, we need a motion.
Motion to approve.
Second.
All right, all those in favor?
Aye.
Aye.
Okay, we got all the ayes. Those abstaining? And those opposed? Okay, motion passes.
Fantastic. Down to our last subject for the day. So turn your attention to page 89 in the packet of materials posted on the website, and we'll turn it back over to Deanna Moretz.
Thank you, Roger. Yeah, so we've got a class update on the oral fluoroquinolones. If we could go to the next slide, please. Thank you. So the last time we reviewed this class of drugs was in 2018. So the purpose of this update was just to see if there was any new evidence for efficacy and safety of oral fluoroquinolones. If you're interested what drugs we're talking about, they're listed in Appendix 1 on page 107 of the packet. Just a reminder, ciprofloxacin and levofloxacin are the 2 preferred drugs on the PDL. That's so we could maintain at least 1 fluoroquinolone with broad spectrum coverage of gram-negative bacteria, and then also have 1 respiratory fluoroquinolone as preferred option. Our utilization in the 3rd quarter of 2021 was primarily for cipro and levofloxacin. Table 1 on page 92 outlines all the FDA approved indications for the oral fluoroquinolones in patients with normal renal function. You may recall that in the last several years, we've been seeing more and more case reports associated with the safety of oral fluoroquinolones. They've been associated with serious adverse effects, including central nervous system, musculoskeletal, peripheral nervous system, and then we've had some more recent evidence of aortic aneurysm and aortic dissection. So in 2016, the FDA mandated that all fluoroquinolones have a black box warning regarding the risk of these serious adverse effects. And they stated that the benefit for the use of fluoroquinolones for acute sinusitis, acute bronchitis, and uncomplicated UTIs is not outweighed by the serious risks of serious adverse reactions. So the FDA really stressed that fluoroquinolones should be reserved for patients who lack any alternative treatment options. Also, as a reminder, the routine use of fluoroquinolones in children is generally not recommended. There is FDA approval for plague and anthrax and complicated UTIs for cipro. And then Levaquin just has the inhaled anthrax or plague indications. So since our last review, there have been several systematic reviews that have been published, and 4 high quality guidelines were updated. So if we'll go to the next slide, I've summarized what the CADITH, the Canadian organization, identified. So they stratified their research on these systematic reviews by indication. So the first one was otitis media, and they found that there was no evidence available for the use of fluoroquinolones in patients that couldn't take beta-lactams. For intra-abdominal infections, the systematic review found that fluoroquinolones do not differ from beta-lactams, ertapenem, or a combination of ceftriaxone and metronidazole in intra-abdominal infections in terms of safety or efficacy. And then the systematic review also discussed this 2017 Surgical Infection Society guideline, which recommends only IV moxifloxacin or Cipro with metronidazole for empiric treatment of patients, adults with low risk of infection. And there's been a real focus on making sure that we're not prescribing fluoroquinolones when there's high incidence of resistance. And then they went on to say that moxifloxacin is not recommended in pediatric patients unless there's no other options that are available. For pneumonia, the recommendation that came out of that systematic review is that in patients with severe community-acquired pneumonia, beta-lactam macrolide combinations may be more effective than beta-lactam combined with a fluoroquinolone in reducing mortality and length of stay. Next slide, please. Thanks. So when they looked at other respiratory infections besides pneumonia, so rhinosinusitis, bronchitis, and bronchiostasis, they found that moxifloxacin and levofloxacin had pretty high clinical cure rates in patients with rhinosinusitis. And then there was a meta-analysis in patients with bronchitis, and that showed that there was no difference in pathogen eradication between the fluoroquinolones, the macrolides, or the beta-lactams. For bronchiostasis, there was 3 high-quality guidelines that recommend fluoroquinolones be used as second-line treatments for patients that have a high risk of treatment failure. And then the final CADITH systematic review was focused on UTIs, and this was kind of subdivided as well. So for patients with pyelonephritis, they found the clinical success rates weren't different between cefaclor, ciprofloxacin, and norfloxacin at weeks 4 to 6. When they looked at patients with cystitis, they found that fluoroquinolones were effective, but the advice was that they should be reserved for more invasive infections to avoid inducing bacterial resistance. And then finally, they looked specifically at the incidence of acute psychosis, I think because of the CNS adverse effects that had been reported with fluoroquinolones. And they found that there was cases not only with the fluoroquinolones, but with penicillins or Septra when used for UTI. All right, next slide. So there was an interesting systematic review focused on the association of fluoroquinolones and the risk of aortic aneurysm and aortic dissection. And the pooled results of 9 studies showed that it appeared that the use of fluoroquinolones did increase the risk of these cardiac adverse events. And then they went on to stratify it by comparators, and they showed that compared to zithromycin and amoxicillin, the use of fluoroquinolones resulted in a higher risk for aortic dissection and aortic aneurysm. But in contrast, when they looked at amoxicillin clavulanate or ampicillin subactam or Septra, compared to fluoroquinolones, there wasn't a higher risk. So the systematic reviewers concluded that since the fluoroquinolones had a similar risk of these cardiac adverse events compared to some other broad spectrum antibiotics, it's possible that the risk of aortic aneurysm and dissection could be related to the underlying severity of the disease, but not the antibiotics themselves. So their suggestion was further prospective studies are required to clarify the association of fluoroquinolones with the risk of aortic aneurysm or aortic dissection. Next slide, please. So we have 4 separate guidelines to take a look at. The first was in 2019, the American Thoracic Society and Infectious Diseases of America collaborated to update guidance on management of adults with community-acquired pneumonia, and the respiratory fluoroquinolones, Levaquin, moxifloxacin, or gamifloxacin, they're recommended for outpatient adults with comorbidities such as chronic organ diseases, diabetes, alcoholism, or if they don't have a spleen. And then there was some more guidance that was issued. A couple more organizations were involved this time, including the CDC and the European Respiratory Society. They came out with a new guideline on the treatment of multi-drug resistant TB and suggested that moxifloxacin or levofloxacin should be included in a regimen for patients that are getting treated for multi-drug resistant TB. This recommendation is what's prompted our recommendations that I'll discuss in just a second. Last 2 guidelines are from NICE on the next slide. So in 2019, NICE updated their guidance focused on antibiotic prescribing for community-acquired pneumonia in adults and children. And basically their recommendation in the UK is that levofloxacin is only recommended as an alternative for adults that have high severity pneumonia and a penicillin allergy, and they don't recommend it be used for children under the age of 18 at any time. Interestingly enough, NICE also focused on some antimicrobial stewardship guidelines and basically said fluoroquinolones shouldn't be used for minor infections or infections that are self-limiting, of course, not to treat non-bacterial conditions. And if it is going to be used for mild to moderate infections, it only should be used if there's other antibiotics that are inappropriate for those conditions. Next slide. So finally, we have an expanded indication. Delafloxacin received expanded approval to treat adults with community-acquired pneumonia. When this drug first came to market, it was initially indicated for treatment of acute bacterial skin and skin structure infections caused by susceptible bacteria. For this expanded indication, there was a single non-inferiority double-blind trial that was conducted, which compared delafloxacin to moxifloxacin, and it was found that the drugs were pretty much similar. There was non-inferiority. So that's how they got the expanded indication through the FDA. Next slide, please. So the recommendation is based on review of the recently published evidence to add moxifloxacin as a preferred agent to the PDL. So that would give us 3 preferred oral fluoroquinolones, ciprofloxacin, levofloxacin, and moxifloxacin. And we'll review the drug costs in executive session. Any questions?
Good job, Deanna. Any questions for Deanna? And we do not have any public comment on this topic either. So again, the recommendations are on the screen.
Moving forward. Motion?
Based on the review, recommend adding moxifloxacin as preferred on the PDL, and then we'll review costs in executive session. Any questions or a motion?
Motion to approve.
All right.
Thank you, Kat.
Second.
Okay.
Thank you, Pat.
All those in favor?
Aye.
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 Anyone abstaining? Anyone opposed? Okay.
Well, with that, we've made it through our agenda. We need to go into executive session to review a few classes. I need to read a small blurb. Sarah Fletcher's been working to get you prepared to go into the breakout room. So with that, I'm going to read this blurb and then pause the recording as we go into breakout. No decisions will be made in executive session. We'll come back out, and anybody remaining in the audience will hear our deliberations and recommendations. P&T committee will now meet in executive session for the purpose of consideration of information records that are exempt from disclosure by law. Executive session is held pursuant to RS 1926602F and RS 44356 and 2, which allows the committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial drug differences between drugs within the same therapeutic class that's necessary for the committee to make final recommendations or comply with the requirements of RS 44353. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to report on any of the deliberations during the executive session except to state the general subject of the session as previously announced. No decision may be made in executive session, and at the end of this executive session, we will return to open session. All right, we're just getting reorganized after executive session. I've just restarted the recording. Let me make sure that we have our committee members back out in open session. If the committee, let's see, recording started, will unmute yourselves. Helps us to prepare for the final vote. Also confirm that we have all the members and we have our quorum for open session. Got most people. Tim, are you able to unmute?
Yeah, I'm here.
Wonderful. All right, Pat, are you able to as well? Make sure we didn't lose you in the transition. You bet. All right. I'm going to lump together the recommendations that we reviewed in executive session. So after reviewing executive session for the sickle cell disease after the literature scan, the recommendation is no PDL changes are recommended. And for the fluoroquinolone drug class update, again, after review in executive session, no additional PDL changes are recommended. Any discussion, questions? And if not, we'll entertain a motion. I know you just don't want to leave the meeting. You have to go back to work. We're leaving you out too early, but we do need a motion to approve. Thank you, Russ.
Second.
Thank you, Pat.
All right. All those in favor?
Aye.
Aye.
Anyone abstaining? All those opposed? We have done it.
Fantastic. Well, thank you for another outstanding meeting. That concludes our April P&T meeting. We will next reconvene on June 2nd. And with that, thank you all. Really appreciate your volunteering for this important work. So take good care and go enjoy the last little shreds of sunlight that we've got out there, 70 degrees. So we'll give you an hour back. Thank you, everybody.
You.
Thank you. Thank you.
Thank you.
You.
Thank you.